Greetings. Welcome to Grand Rounds in Urology. Today I'm here with Dr. Masters Richards. He is a vascular and interventional radiologist at Desert Radiology in Las Vegas, Nevada, and I am going to be interviewing him today. I am your host, Hillary Durstein, nurse practitioner. I am in Las Vegas, Nevada, and today we're going to be discussing cryoablation of small renal masses, tips for the APP. Disclosures. Dr. Richards has no disclosures. I myself do have disclosures. I am a nurse educator with Bayer. And while I work for Bayer, the views that I share today are my own and not official company statements. First, we're going to go through some introductions. We're going to look at epidemiology, indications, and contraindications for referring patients for cryoablation of small renal masses. We're going to look at anatomic considerations, procedure description. We're going to do a couple case studies and talk about follow-up and surveillance today. So first, when we look at epidemiology, in 2019, approximately 7,300 cases of renal cell carcinoma were diagnosed in the U.S., leading to over 14,000 deaths. RCC represents 90% of malignant renal tumors, and more than half of these tumors are discovered incidentally. Some of the causes can be obesity, advanced age, tobacco use, and those are the main risk factors that we find. T1A lesions represent 48 to 66% of RCC, whereas only 17% of patients have metastatic disease at diagnosis. So when we're looking at appropriate candidates for IR referral, we want to think about patients who are not good surgical candidates, such as some elderly patients with significant comorbidities such as CHF, end-stage renal disease, COPD, patients who opt for minimally invasive approaches, and size less than 7 centimeters, T1B, which is 4 to 7 centimeters, and body habitus is generally not an exclusionary criteria. Novel anticoagulation therapy meds such as Coumadin, aspirin, clopidogrel are not necessarily exclusionary. So let's look at some indications and contraindications. The AUA and European Association of Urology have considered radiofrequency ablation and cryoablation to acceptable treatment options for T1A lesion. Microwave ablation is also commonly performed. For T1B, 4 to 7 centimeter tumors, standard of care is nephrectomy. However, as previously discussed, some of these patients could be referred to IR if they are not good candidates for surgical criteria. Active surveillance is also utilized for T1A up to 4 centimeter tumors in more elderly patients and those who have significant comorbidity. And some contraindications are coagulopathy, such as INR over 1.5, platelets less than 50,000, widespread metastatic disease, and also anatomic location, which Dr. Richards will discuss further as we move along. So Dr. Richards, talk to me about some anatomic considerations in these patients that are referred to you.
Great. Thanks for the excellent introduction, Hillary. Honored to be here today to discuss CT-guided cryoablation of renal masses. It's something I'm pretty passionate about, and a substantial amount of my interventional radiology practice is devoted to cryotherapy. So it's actually a perfect time to talk about this because I had a couple of cases this week that I did, and one of them I couldn't do because it was too close to the colon. So just some general information first. There's some different scoring systems that exist in the surgical literature to get a sense of how complex the tumor is with respect to the anatomy and in relation to other structures in the abdomen. This can help us predict if there are any increased risk for complications or damaging other structures. So there's something called the renal nephrometry scoring system. It's here on the screen. I'm not going to get into the details, and the urologists tend to look at this more than interventional radiologists, but there's a scoring system where 4 to 6 is low and 10 to 12 is high complexity, respectively. So it takes into consideration whether the lesions are exophytic, meaning they're bulging out from the capsule, or endophytic, how close they are to the collecting system or the renal sinus, whether they're anterior or posterior. And so all these things are very important when evaluating patients for consideration of cryoablation. There's also another system called Padua that looks at this.
So let's go talk about the cryoablation procedure. Not a lot of us get a lot of experience talking to interventional radiologists, as you and I have had a long relationship and working together in the hospital setting. So tell us more about this cryoablation procedure from your perspective and what we can expect when referring patients.
Okay. So traditionally, interventional radiologists would use general anesthesia when doing cryoablation. That's the way I was trained in private practice settings, and I think more commonly, even in academic contexts. We're now using moderate sedation, just fentanyl and Versed, with RNs administering this. It's done on an outpatient basis. So we usually put the patients in the prone position, but it's sometimes necessary to do it oblique or lateral. So the way we do it is we do a scout CT scan, usually without contrast. That gives us the lay of the land. We have a pretty good idea from the planning scans where the tumor is. Now, if it's endophytic, it's often difficult to see, especially if it's a small lesion and it's not involving the collecting system. So occasionally we'll give 70 to 100 milliliters of iodinate in contrast and then get a 70-second regular delay phase, and that usually makes the lesion pop. The contrast is also nice because it is excreted through the kidneys, as you guys know, and so it stays around for 20 to 30 minutes. So you can kind of see how your cryoablation is going as the tumor is being frozen. So we prep the skin using sterile technique. I always biopsy the mass with the 17-18 coaxial biopsy system if it has not already been biopsied. It doesn't really change the management, but it's nice to get a tissue diagnosis. I recently biopsied someone who had a history of pancreatic neuroendocrine cancer. That's kind of a low-grade neoplasm that even with those patients, they can have stage 4 disease and receive multiple treatments and live quite a long time. That particular lady had a enhancing renal mass, and I biopsied it, treated with cryoablation. It came back clear cell renal cell carcinoma, but it certainly could have been a metastatic lesion. So we do the biopsy, and then we pull the biopsy needle out. Then we use a cryoablation probe. There's about 3 or 4 on the market currently. I use one specific company that I tended to train on. This one uses 2 freeze thaw cycles. The thawing is actually important because the mechanism of cell death in cryoablation is to freeze the intracellular cytoplasm fluid. Mm-hmm. And when you thaw it, it punches holes in the cell membranes of the tumor, so the water will go in and out of the cell membranes, and that's how it causes cell death. As you guys probably are well aware of, renal cell carcinoma tends to be hypervascular a lot of the time, so mm-hmm. we will cauterize the ablation tract because we don't want any bleeding. You gotta be a little careful with that because you don't want to burn the hemidiaphragm or the paraspinal muscles, but we certainly want to cauterize the tumor. So we take the probes out, we do a post scan. That's just checking for any potential perinephric hematoma or any complications, and we'll talk about the complications later. I usually watch these patients for 3 to 4 hours. I let them eat if I'm confident there's no bleeding and they're doing well. So traditionally, I've discharged the patients home with a very short course of narcotics, oral narcotics, and a stool softener. But more recently, I've just been instructing them to take acetaminophen. That's usually adequate. There's just kind of very minor post-procedural instrumentation pain. So,
Okay. Well, that's really good to know about the freeze-thaw cycle and causing cell death. I wasn't aware of that. So really good pointers for us to know how cryoablation works from an outsider's view in urology practice. So moving on, talk about some potential complications that we see with these patients that can happen.
sure. So the big one is bleeding. Renal cell carcinoma is often hypervascular. However, less than 5% of the time do we get a significant bleed. I mean, it's actually kind of rare to get hematuria, but they can have some minor gross hematuria. It's pretty common to get a perinephric hematoma, but they're often very small. I did one this week, which was a recurrence actually, that was about 12 millimeters in diameter, and there was just no perinephric blood at all. So I think the cauterization can help too with that. Probably done about 100 cryoablations in my career in the last 5 years as an attending interventional radiologist, and I've only had to do angiograms on two patients who bled. So it's it's under the 5% quoted stat in the literature. One of those patients needed an embolization. I coiled the small artery that was bleeding. The other one, the bleeding had already stopped by the time I got in there. So urine leak or urinoma, that's pretty rare. 1% is what's quoted. I would say the literature underestimates nerve damage. It's quoted as less than 1%. I would say it's a fairly, just anecdotally speaking, I would say it's as high as 10%. It's usually a paresthesia kind of phenomenon where they get pins and needles, or a hypoesthesia, like a kind of mild lack of sensation in a linear band around the flank. The patients usually are slightly irritated by it, but it usually improves with time. Theoretically, frostbite and skin burns are possible. However, when we perform cryoablation, it's usually so deep in the retroperitoneal space that it's just not an issue. I've recently started doing breast cryoablation, and you have to be much more careful about that because it's so close
Much
to the
more
skin.
surface. Yes, for sure.
Infection is small risk. I usually give a dose of 400 milligrams of ciprofloxacin IV times 1 just before the procedure.
Mhm.
Prophylactically, I really haven't had any major complications with infection. So another concern and that we have is non-target ablation or damage to ceramic structures. I've treated patients with lesions very close to the pancreas. I've warned them about the risk of pancreatitis. A bowel injury could be potentially catastrophic. I canceled the procedure this week for a patient with a 3.7 centimeter mass that was right next to the colon. I was about a centimeter away from the colon on the supine scan, the planning scan.
Mhm.
And then when I flipped her prone, it was immediately adjacent to the tumor, the colon was. So I even tried to inject some sterile water to called hydrodissection to try and move the colon out of the way, and then that didn't work, so I had to cancel it. But luckily, we have our excellent urologists to help us.
Well, thank you.
And pneumothorax sounds like a weird risk, but you do go intercostal to treat these, and so there's a thin layer of pleura that you have to cross. And I've definitely had a small pneumothorax putting a nephrostomy tube in, but it's pretty uncommon with cryoablation.
All right. So let's look at case number 1. This is an 80-year-old male cryoablation consult. So Dr. Richards, this is your patient that you treated. So take it away.
Yeah, thanks, Hillary. So on the image on the left, that's a non-contrast axial image, and it's actually very difficult to see the tumor because it's endophytic, so it does not bulge the capsule. There's no convexity to the capsule. So in this particular case, I gave some contrast intravenously, and then you can see this heterogeneous hypoattenuating or darker mass in the posterior aspect of the kidney. So clearly you can see the tumor there. So
Okay. And next, we're going to look at this procedure. And these are your procedural images that you take.
correct.
Mhm.
And this is the same patient. It's just the orientation looks a little weird because now we're prone. The patient is prone, whereas before it was patient was supine. So in the left image, we can see the cryoablation probe going right through the mass, which is what we want to do. And in the middle image, we see the actual ice forming, the hypoattenuating.
And this is that
Correct.
mass right here that
Mhm.
we're going after.
So we see fluid all the time on CT. It looks kind of dark. It's darker than soft tissue, but certainly not as dark as air. And because ice is still fluid, but in a frozen state, it shows up as fluid attenuation.
Okay.
And then on the most right image on the screen, this is the post-procedural image. And what I'd like to point out to you here is this is the tract of the cryoablation probe. So that's what was cauterized, as well as the tumor, and you can still see the tumor here. And then there's a couple foci of gas here from the instrumentation, but there's no perinephric hematoma. There's a nice fat plane around the kidney there.
All right. That looks great. I like how you can explain the images that we see. All right. So moving on in this case.
Okay, so the same patient, we got a surveillance contrast enhanced renal MRI in December of 24. Procedure was originally done in January of 23, and pathology reveal clear cell RCC. What I'd like to point out here is the scarring of the kidney. And in clinic, I get asked all the time by patients, so are you going to take the tumor out? And I say, no, I'm not a surgeon. And I say, we treat it and kills the tissue. And basically there's a contraction of the tissue and scar tissue formation. So this divot or concave appearance is what we want to see. And we're looking only dictate the studies from a diagnostic standpoint. Afterwards, we want to make sure there's no nodular enhancing mass in the ablation zone, because that would signal that there might be some recurrence. But this looks clean in this case.
All right, we're going to move on to case number 2. So here we have a 76-year-old male who presents for evaluation of potential cryoablation. Okay, Dr. Richards,
Okay.
what do we got here?
Okay. So this one is also mostly endophytic, so it's not really bulging. So I also gave contrast to help better visualize the tumor here. It almost abuts the collecting system in this coronal image here, but it's still not super close to the renal hilar vasculature.
And how big would you say that mass is, just on your view here?
About 3 to 4 centimeters. So this is probably a larger T1A lesion.
Okay.
So just under 4 centimeters. Mm-hmm. Okay. So this is the same patient showing the intraprocedural images. On this particular image, we see 2 of the cryoablation probes here. In this case, we used another one, which we can't see on this particular image. This is a good example of showing the intercostal space here. And then there's a thin sliver of lung parenchyma here. So I definitely want to avoid going through the lung because the risk of pneumothorax would be quite high with these probes. But you can see the ice form around the cryoablation probes, and then there's some fat stranding, a little bit of artifact from the metallic instruments here. But
So the larger the tumor, the more probes you use, correct? Makes
Yep.
sense.
And the reps from the companies have charts And, basically, we always meet and talk about the tumor morphology and how big it is in 3 different planes, the AP transverse and craniocaudal planes. And
Okay.
when you add the probes together, it changes the shape of the ice ball. So
Oh, all right. So some pre-planning makes sense. All right. And so this is case 2 post. Tell us what you see here.
okay, so this is a good example of a different ablation zone, and you can see where the tumor used to be, but notice that there's some concavity here and here, so it's more prominent anteriorly, but we can see it here. So that's just the scarring beginning, and this is a non-contrast image. On the post-contrast image, what I'd like to show you is there's no enhancement within the ablation zone. So the tumor's dead. The normal kidney enhances physiologically. And there's a little dense area over here anteriorly and laterally, but it's on the non-con, it's pretty similar. So that's not truly enhancing. So it looks good. It's a clean ablation zone.
All right. So let's talk about surveillance. Tell us what that's like, Dr. Richards, what you do for surveillance.
So I like to do a 3-month follow-up contrast enhanced renal MRI. The reason why we wait 3 months is we want to let the inflammation subside.
Mhm.
If you image the patients in 1 or 2 months, oftentimes there's a false positive phenomenon. You might get some scar tissue that has some enhancement, and it can cause some confusion. If the patient already has an oncologist, it's important that we talk to them and get on the same page about when the imaging is being done.
Okay.
And I basically do a 3-month scan after, and then I do it every 6 months twice, and then I yearly after that, just following the NCCN guidelines,
Mhm.
National Comprehensive Cancer Network.
Mhm.
Yeah.
Okay. So here are some of the resources that we used in order to prepare this lesson for you today. And if there's any questions or comments, please feel free. Dr. Richards was nice enough to say, hey, I'll put my email in there. And if you have questions or comments, please feel free to send him a message. And I thank you so much today for your time. And thank you, Dr. Richards, for joining us and giving us this great lesson on cryoablation from your point of view, because we just don't get the chance to see you all too often back in those rooms. But luckily, I have great relationships, and I hope that you all can build them too in your practices with your IR counterparts and and have these opportunities for further education along with them. So thank you so much for being a part of our session today. Grand Rounds in Urology, the leader in urology education.
Thank you for the opportunity, Hillary. It's
Yeah.
great talking today. Yeah.
Thank you so much.